In the position that Mississippi is right now, we are losing money whether or not we had some kind of expansion or not. The delivery of healthcare services in the old bricks and mortar purview like I grew up in, where you had a large hospital that was a center of of medical care, is not the methodology for today. For example, if you go to get your knee scoped or something, all the orthopedic surgeons have their own private operating rooms, their own private stuff, and colonoscopies or heart deals or whatever you're doing that used to be in a hospital setting is no longer being done there. It's being done on outpatient. And in fact, in some instances, some of these are being sold to private equity groups. So healthcare has moved way beyond the traditional way that I knew it, which was growing up with a major hospital. I went there for shots and everything else. That's not going to be the answer here. What we really have to do, and I was meeting with Dr. Eddie and them on this very point yesterday, is determine how we're going to deliver health care to our citizens in the most economical way and with the greatest coverage for what is necessary, primary health care, the OBGYN, the hearts, those kinds of things that we expect to be within some reasonable distance of where you are. Now, to do that, we're going to have to look at the whole way we're delivering health care. And that is way beyond coming up right now. I think we're getting reimbursed at like 84% or something. And we're looking at other reimbursement models to assist the hospitals. Met with them about a month ago about that. But that really is a triage or a Band-Aid on not facing the realistic operation that healthcare is going to be delivered differently. And I have been working with FQHCs and other delivery of healthcare professionals on how we would do that. That's the long-term solution. The short-term solution is this, short-term economics. But if we prop up a non-economic method of operation or doing business, it's going to fail later. So I think it's time for a really realistic expectation. And you see, like in England, I think 39 or 40% of people now have private pay in England, and you have a year to wait for any kind of operation or whatever. Our people are not going to put up with that. They're not going to wait a year to do whatever that needs to be done, and the quality is maybe questionable, and so people buy private insurance, and then you end up by having the individuals who may not have the economics to afford private insurance being left literally out in the cold over a period of time. So I know that's a longer question, but we got a bigger problem than picking up another 5% of reimbursement here. And I think it's time to realize that, and I anticipate that we'll be addressing that this coming session. Some of it you'll see in the work that Senator Boyd is doing on how we address the reimbursement model for adoptions and other things. So you'll see some other healthcare things, but to use the old saying, the elephant in the room is the economic model that we're operating our hospital on is not working. It is really devastating. You're going to have hospital closures, some by the end of the year, and that model has to be really, the bright light needs to be thrown on it, and we need to decide if this is the way we're going to go. Now, once you do that, then I think the funding really is a result of that, not a cause of it. So that's a longer explanation, Todd, and it's very sophisticated. What we're dealing with is a multi-billion dollar. We put up $1 billion a year. The feds put up about $4 billion a year on this. It is a huge operation. It is very sensitive to public opinion. Everybody wants their health care as quickly as they can, particularly in an emergency situation or pregnancy situation or problem, catastrophic situation. So we've got a lot of balancing to do, but I don't think we have our model set up right now.